Welcome everyone. I live in Australia and I'm in Melbourne, down south, and it's about 11 o'clock in the morning here. So good morning to those of you in the morning and afternoon, and good evening. And thank you for joining and taking some interest in a topic that has been very passionate to my heart for some time. I've heard this title as Are We Ready? And I've had a lot of questions over my careers and seen a lot of things happen in my clinical career as a nurse. And I've started to formulate questions, and I'm probably going to stimulate more questions than answers here today. But at least it gets the ball rolling. And I really am feeling passionate about this and feel there's quite an urgency around this that involves nurses, particularly around nursing preparedness for natural disasters and the health implications around them. So I was at a forum online a couple of months ago, and I heard someone in the audience say all nurses are disaster nurses. And to be honest, I thought, yeah, that's right. But I started to question, are we? And where is nursing heading? And what our education academia is doing, and are we prepared? So I started to look into this and into some research, into some papers, and I really struggled to find what I was looking for, and that being nurses' preparedness around climate change and natural disasters. So this stimulated from two stories and experiences that I had in my clinical career. And, you know, we all had those ones, you know, incidences that happened, and, you know, you'll take to your grave that you never forget. And I'm really pleased to say that as tragic as the circumstances were, you know, a lot of lessons and inquiry has stimulated me out of these experiences, and hopefully for the better. So I wanted to share with you an incident that I experienced back in 2009. I was a clinical nurse in the emergency department. I was probably 15 years post critical care emergency training, and I was triaging an ambulance presenting one morning. We knew it was going to be a busy day. We're in the middle of a heat wave. It was a day 3 of 47 degrees. That's very unusual for us here down south, almost near the Antarctic, to be honest. And however, my first presentation ambulance that came through the door at 8 o'clock was an elderly gentleman. And I said to the ambulance, oh, what's wrong with this patient? You know, what triage presentation does he come with? And they said, oh, it's a social admission. And I said, oh, come on, guys, we're going to have a really busy day here today. Is there anything you couldn't sort out, you know, out in the community before bringing them here to the emergency department? And they said, well, actually, his wife was found dead in bed that morning. And that really shocked me, because I had no idea, and I had nothing in my trainings to prepare me for that, in the fact that the heat wave that we experienced 2 days before, temperatures hadn't dropped below 30 overnight. And of course, I didn't think that the human body recovery requires a temperature under 20. And I hadn't even acknowledged the heat wave that we're experiencing and the impacts out in the community. And so this taught me a very big lesson, and it stuck for me for a long time. And I thought, what am I missing here? What is the department missing? And what are my other colleagues? Why aren't we aware of what's happening out there within our community? And heat waves are a very tricky concept for emergency departments. We don't traditionally keep any statistics on the impact within our emergency department and hospital facilities. The conditions are very vast, from heart attacks to abdominal pain to gastros to seizures. And so it's really difficult to identify as a triage nurse the impacts. The only statistics I could find in the time were really the ambulance service kept stats on their cardiac arrests. And of course, it had increased 5-fold during a heatwave period. And so this, you know, we had no warnings. We had from our, you know, government, a state government health department. And so we were really, I felt, going really quite blind in the fact that we hadn't acknowledged even our environmental circumstances. The other phenomena that we had a couple of years later, back in 2016, it was November, we had this phenomenon called thunderstorm asthma. Once again, metropolitan hospitals hadn't heard of this, despite rural and remote hospitals. And it was an incident where we had this storm one day. It was high humidity, and it was over 30 degrees in late November, where our summer down here starts. And season between October and December is known very well in our rural hospitals and healthcare facilities of thunderstorm asthma. This is where the ryegrass is at its peak, and it needs certain environmental conditions for the pollen of the ryegrass to break open into the atmosphere, and they're very fine particles, and they get into the lungs. We had a storm that was coming across the bay, and we were very fortunate, probably here where I live in Frankston, an hour south from Melbourne, in the fact that we didn't get a lot of impact, but we had fatalities this day, and hospitals around the state, being metropolitan and CBD hospitals, were absolutely inundated with sudden onsets of respiratory conditions, of asthma and wheezing. We suddenly had a waiting room full of asthma. GPs and our chemists and drugstores ran out of inhalers in the morning, and we suddenly had, intubated 4 respiratory failure patients in resus within about half an hour. But we still didn't click that something was going on out in the community. We didn't activate our mass casualty respond round plans, and we didn't even question it. So once again, it was a lost opportunity that healthcare services weren't working with their primary health, with their chemists and their GPs, nurse on call, and we were going blind once again. Naturally, fatalities occurred. Ambulance services absolutely ran out of resources. They even turned their computer system off because they couldn't believe the sudden onset of numbers of requests for ambulances. And a state inquiry occurred, and the hospitals were deemed as negligent, as well as the ambulance service, for not recognising and preparing for such a disaster. So these 2 lessons left me feeling quite vulnerable throughout my career, and made me question just how much do nurses on the floor know about these circumstances, and acknowledge the environment out there and where people are coming from, and what are we teaching in our undergraduate and postgraduate courses for nurses. So also, what is the awareness of our health services? We didn't in the past acknowledge our Bureau of Meteorology alerts. We didn't look at pollen counts, and we on certain apps. We didn't look at our emergency services apps and warnings and systems, and we were quite oblivious to all of these factors. And of course, also was the health department. So I started to look at literature around this, particularly around nursing and disasters, and the health implications of that. I found many papers, thousands, on nursing preparedness, willing to participate, and in regards to disaster events. But I really struggled to find papers around addressing nurses' perceptions on the concepts of climate change within the normal code of practice. And there again, let alone papers on disaster nursing in the context of climate change and the impacts on human health. So in regards to my literature research, I really felt that I'd found a gap, and a big one at that. So as we know from Nightingale and our history, nurses have a duty of care. And I felt, how can we have a duty of care when we're not aware of all of this? We're not adhering to environmental alerts and alarms out there, and we're not even recognising the conditions of what our patients are presenting with on normal days, let alone on extraordinary, extremist days where disasters occur. I felt also that technology has a big role to play here, but also hinders our concepts. Nurses today, we are very technical. We're almost paperless in our practices, and we become very paralysed when they break down and we have outages. But, you know, we're failing to properly assess our patients and take in considerations where they come from and their circumstances prior to their arrival, whether it be a chronic illness or a sudden onset induced by climate change, environmental health aspects, and disasters. So technology is good in some ways, is that it gives us alerts and alarms out in the community. And I think in our country, certainly through lessons learnt, we're getting better at this, particularly around bushfires. But in regards to air pollution and quality like that, you know, disease surveillance after floods, not so much. There is weak spots throughout them all. So what path is nursing on? And this is what I want to try and understand. As I said, nurses are very risk adverse, and we are very technical these days, and we're becoming very specialised. And is that a good thing or is that a bad thing? I don't know. It's, you know, I do find that nurses are very siloed in their practices and have a very poor understanding of the global requirements and the combinations of varying specialties that, you know, disaster nursing demands, and let alone understanding the environment that our patients come from and their vulnerabilities. So I think education and training is the key, both in undergraduate and postgraduate. I think we're starting to advance in the postgraduate space, but as for the undergraduate, I'm struggling to find evidence around environmental health, planetary health, and disaster nursing per se in the undergraduate space, and also within the workforce itself. And I find that a lot of our mature and specialised nurses are mostly relying on their prior experiences and exposures of living through a disaster event, and then applying that to their practices. So the devil really is in the detail of training, both undergraduate, postgraduate, and within the workforce itself. In this aspect, these days, nursing is structured, as I said, to be risk adverse, protocol driven, and that is a good thing for patient safety, but there leaves little room for flexibility and adaptations. On a daily basis, workflow practices, mostly for the here and now, are challenged by excessive demand around the world, and we know that we have a shortage of nurses around the world, and leaves little room to acknowledging the alerts and warnings out there. Recognition of environmental health implications, whether it be during normal practice or under extreme conditions of a disaster situation, these concepts are often deemed too difficult to consider and challenging to rectify. Nurses don't have time for that. This is where clinical triggers and thresholds need to be set for us clinicians on the floor to acknowledge clear learnings and warnings and alerts of potential natural hazard events impacting our health services, and force clinicians into practicing risk adverse proactively and in readiness with prepared strategies for recognition. Yes, we have competencies in disaster nursing, both for the novice and the specialised nurse. They're divided up into 8 domains, thanks to the International Council of Nurses, from preparedness and planning throughout the cycle of the disaster management, and of course covering safety and security, assessment, intervention, recovery, and law and ethics. And we also have position statements. It's interesting to know that they're separated out here, one for nurses and disaster risk reduction, response and recovery, but a separate one relating to nurses, climate change and health. We need to teach our young and to cover these aspects of these position statements. Nurses remain an unused resource in disaster risk reduction, according to the statements, and they respond and recover for communities around the world. They go on to say that the ICN statement believes that the involvement of nurses is essential to prevent new and reduce existing disaster risks. They see the importance of nurses in reducing hazard exposure and vulnerabilities to disasters, and increasing preparedness for effective response and recovery is important in the nursing practice. These statements view strengthening resilience throughout the nursing profession and the nation's capacity to underpin by the ability of its health workforce is really important. Under the statement of nurse climate change and health, they state that climate change is the single greatest health threat facing humanity, with profound implications on human health and well-being. Nurses practice in increasingly affected as more people experience the health impacts of climate change and as these increasing strains healthcare systems. Nurses are critical as climate actors, they state, and climate action by nurses drive climate mitigation and adaptation strategies, policies and programs, and is key to the future of people's health and the planet. So are we acting enough on this? This is my question. These statements need to be more promoted amongst our undergraduate nurses. Teaching is the key. Historically, nurses have partaken in mass casualty drills and exercises, here in Australia at least, in the clinical environment, managing mass trauma, mass casualty events, which are mostly technically driven and industrial accidents in regards to disasters, but never anything around natural disasters. These technical disasters are quick, short-lived, and managed efficiently. But what about prolonged droughts? What about prolonged heat waves, bushfires, and bad pollution? What training has lacked is, however, to manage those long protracted disaster events, such as I said, droughts and extreme heats and bushfires. However, the pandemic has provided us with tangible evidence to look back on. Lasting over several years, it provided us evidence during this type of event in the profession's own well-being, coping strategies, and mental health implications. Here in Australia, there is significant lack of disaster training in undergraduate studies and very few postgraduate courses run at universities. Primary and public health courses have been doing the heavy lifting, I have to say, for some time. We need to teach our young and start at the undergraduate level. I truly believe that part of our curriculum needs to incorporate planetary health. This is around developing sustainable and healthy cities. So looking at categories there, the one that really interests me is down the bottom where I've highlighted in yellow, increased resilience to floods, storms, and droughts. Professor Tony Capon actually gave us a presentation at university at the beginning of the year to their lecturers, advising that planetary health really needs to be incorporated in all courses throughout the nursing curriculum. However, we mustn't forget also the UN Sustainable Goals, disaster risk reduction, particularly the goals number 3, 11, 13, 14, and 15. These incorporate good health and well-being, sustainable cities and communications and communities. But one that really does interest me here, once again, comes up as climate action. And of course, also involving life below water and life on land. So what are we doing around climate action in the nursing profession? We need to understand the determinants of health of our vulnerable communities that we serve. So we also need to incorporate in our nursing the eco-social approach as well as the biomedical approach. And I think the pandemic sort of taught us this with lockdowns and how the economy nearly collapsed and the social interactions nearly collapsed during this time. We also need to acknowledge the interdependence of mankind during disasters and their vulnerabilities. And of course, it sums up by saying that planetary consciousness into everyday life needs to be incorporated. And I think we need to acknowledge this in nursing. So the health implications, what we're really looking at here is disasters and risk outcomes. So of course, morbidity and mortality, the impacts on infrastructure, particularly in severe weathers and storms and floods. We need to look at the hospital surge and also as a refuge point as well for the general community. Changes in disease transmission risks. Here in Australia, normal tropical diseases are heading south, and we're finding more evidence of that. A big element on psychosocial effects and psychological effects. And we've just passed our budget here in federal government this week here in Australia, and mental health and wellbeing has been given significant amount of money. Also sociological effects, economic effects, nutrition, malnutrition, and population movements as well. I don't think nurses are ready for mass displacement of populations with sea level rises, flooding, severe storms, and fires. However, we are coming into, going through leaps and bounds in this area, particularly around public health and medicine. The evidence in literature is growing, and particularly in the Lancet, for example, are becoming heavily invested in these concepts, and with many health organisations invested and partake in the IPCC. So the buzzwords here are really adaptation and flexibility in disaster management, and particularly around the nursing profession. How do nurses adapt? How do we become flexible within our scope of practice? And how do nurses become more aware of the environment in which their communities live? Looking at the causative effects from nature. Progressively, things are changing into the right direction. Here in Australia, some of our legislations are starting to incorporate environmental sustainability and climate resilience amongst healthcare modules. Also, in our Australian Government Department of Health and Ageing, they're starting to acknowledge climate strategy implementation plans. And in my own state of Victoria, the Department of Family, Fairness and Housing and Department of Health Emergency Management Branch run every year annual summer preparedness forums of what to expect in the fire season, the climate, the weather, and the air pollutions in the 3 to 4 months covering over our high risk area months of summer. We have gained some lessons learned, particularly around the pandemic. The global pandemic has taught us much. Some we cherish and some we would like to forget. Let's hope that they are not forgotten too quickly and become embedded into our practice. The problem here is that disasters are happening so frequently that we don't have time to look at the lessons learned and to implement new practices for better management. The health implications that we have learned through the pandemic, as listed here, are quite vast. But I think one thing that we've learned is particularly around supply chains, workforce requirements, and the need for just-in-time learning and to be flexible and adaptable. Policies every time we came to work changed due to the lack of consumables. And of course, towards the end, in the second and third year of the pandemic, the psychological impacts on the healthcare workers started to take its toll. These are the really important aspects, I feel, that in disaster nursing and in our nursing profession as a whole needs to incorporate. We need to be mindful that our communities are watching. Their expectations are high. Here in Australia, communities are being advised that they're not going to have a fire truck at their driveway every time there's a bushfire coming in their way. But hospitals and healthcare facilities are refuge places that the public need, particularly not in almost the response phase, but also the recovery phase and of their chronic diseases. We see this, and we saw this actually in the pandemic. The first 6 months while we watched it penetrate through Europe and overseas in the Northern Hemisphere, our hospitals were deserted. People didn't come, and we didn't have the surge that we normally have on a daily basis. But as soon as the pandemic came and it started to become absorbed into normal practice, then we had the surge of the chronically ill that stayed away for 2 to 3 years. And of course, proved harder to rectify with longer stays in hospital and more demand on the healthcare system, let alone our nursing profession. Our practices need to incorporate more health promotion strategies, and we need to demonstrate that we as a profession can adapt and be flexible to face the endeavours of climate change affecting our health. We have to ask, have we been asleep at the wheel? I don't believe so. We've known for this for a number of decades now. I think nursing is still in the recovery mode of the pandemic, to be honest. It has been a good wake-up call for disaster nursing, but you can argue that it has delayed our preparedness for climate change impacts in the disaster realm, which we will soon and currently now facing and into the future. Our nurses ready for large volumes of displaced populations associated with finite resources, needing to address the basic social determinants of health, that being food, water, shelter, and medicine, is becoming more challenging. Are we ready for the challenges of mitigating infectious diseases and surveillance required? Are nurses ready for the avalanche of mental health and well-being? And are nurses psychologically prepared themselves? We have a long way to go. Disaster nursing needs to be absorbed into the new norm. We need to go about our normal daily nursing, but we also need to build into this new norm an awareness of sudden onset changes as well as slow onset changes related to climate change, and adapt our practices accordingly. So we need to spread the word, get it out there, that yes, all nurses are disaster nurses. And we need to start this at our undergraduate level and within our workforce today. The paradigm is shifting. We need to shift nurses from the current status of reactive models of care to more proactive models of care. This brings in the mitigation and preparation strategies of the disaster management cycle. The occurrences of natural disasters are giving us very little time to recover, let alone implement mitigation strategies for the future, those being from lessons learned. Health promotion is one of these strategies, and it needs to be incorporated into every nurse's scope of practice. Opportunistic learning. So we are on the move. I do think that this issue in nursing is gaining momentum, and we are walking the right path and the right track with purpose. The frequency of global disasters are focusing and forcing us with urgency to realise the global consequences of human health from natural disasters. But we have to ask, like during the pandemic, are we learning on the run? However, when you look at resilience as one of the most trusted professions in the world, we swim against the currents with determination and resilience. And this is what makes our profession increase in resilience. So I bring you back to the question, all nurses, the statement, all nurses are disaster nurses. Yes, I truly believe this. But the question has to remain, are we ready? And I do hope to see you all in May at the Wadham conference, and thanks for listening.
Okay, thank you so much, Nyree, for your great presentation. And I think that your presentation provided us a very deep insight from your experience as well as in Australian context as well. So thank you so much. Okay, so we're going to move on to the Q&A. Sorry, I didn't realize I didn't introduce myself. I'm a SIG chair of nursing, so from the Wadham nursing SIG. So of course, Nyree is a member of the SIG member team. So Q&A, we got some questions. So if you have any other questions, please feel to post your questions. First question is, if I just read out, if you could change standard training and practice, how can you increase buy-in to further education and training from current practicing nurses without adding more demands to current workloads? Yes, well, it's I think it's a challenging question, but yeah, what do you think?
And this I came across two studies, and this is a classic example, one from Finland and one from Sweden. They're a little bit old now, but the principles still apply. Nurses are aware of climate change, its severity and its frequency. You only have to look on the news. There's a flood or a fire North Korea this week, and a flood elsewhere. And so we do understand those ramifications, but we're just too busy with our current demand to cope and even consider it. So I think hospitals per se need to at least make nurses aware and develop thresholds and triggers. And this is what I do in my health facility now. I write disaster plans. So we have thresholds for thunderstorm asthma, for instance. As soon as we get 15 respiratory cases in the waiting room that are presented like within the 1 or 2 hours, that sends an alarm bell. That's the trigger now to think, oh, is this a thunderstorm asthma incident? Every day in our hospital huddles at 9:45, our Department of Health and State Emergency Management Centres will often send out alerts and warnings for the next day, whether it's a heat wave or flooding or air pollution, as well as infectious diseases, of course. And then I spread that out to the whole hospital in these huddles where all our department heads are. And I also write briefs, go to all emails and pop these warnings on the intranet of our hospital. And so I'm writing it for the triage nurse, and I often will ring them and say, this is going to be a really hot day today. Look out for heat-related illnesses. And then I'm also writing it for my clinical staff that are out in the community and in the hottest part of the day. I'm also writing it for our newborn babies being discharged home. And so getting nurses to start practicing in their, their procedures of discharge or visiting in the home environment, talking about their cover for air conditioning and concepts like that, and giving them some health promotion strategies to keep cool. Or boiling water to avoid diseases when they've just gone through a flood, etc. And having enough medicines. We also have a program here in Australia called the NDIS, which is health services for our disability. And we've built into that, and I've helped our hospital facility build into that environmental and disaster management strategies, and having a Red Cross ready plan, and look at that in what is your strategies during a disaster. Primarily here, we're a very hot and bushfire prone country, and so it is looking at what strategies and where would you go, and what connections do you have in the event of bushfires, and leave early. And we also, I write my plans, my heatwave plans and severe weather plans are around the state's warning systems of information to know, watch and act, and leave early, and stay and defend. So they're starting to be built into our practices and our policies and procedures, but also at the ground level, and provide in services as well. So we don't want to add extra burden onto people's clinical practice. We're busy as it is, and we're not really coping with the demand that we have now. And we also run drills in the hospital environment. We do it in conjunction with the Department of Health, and it's multidisciplinary. So we involve the ambulance service and our local councils, and so they can see it. Unfortunately, the scenarios are mostly technical based. So we look at plane crashes and bus accidents, and we'll push, 300 to 400 patients through the emergency ICU and theatre for the day. But we really need to move beyond that now and look at slower ones, but more higher demand of the air pollution and the bushfires and the natural hazards as well. That's where we're falling short at the moment. So I'm not quite sure how to answer that question.
Okay, thank you so much for your a lot of information you provided. So I just wanted, because depending on the way you are working, like in institutions like public or private, does it make change over those trainings and in hospital training?
Look, to be honest, I think when I started this back in 2005, I was a clinical nurse. I could see this. I could see that we needed a bushfire plan and a heatwave plan after my experiences of the triaging that poor elderly gentleman. And I couldn't get a hearing in. Management didn't want to know. As I said, they're so reactive to the demands that they're facing that day. But since the pandemic, and since the severe bushfires and the thunderstorm asthma, people are starting management in health facilities, and I work in a public health facility. It's not a big hospital. It's only about 600 beds, but we're starting to. Our management is taking it seriously and the alert seriously. And all hospitals should have a hospital incident management team, and it's not uncommon that we will stand that up in preparedness for such as a high catastrophic bushfire risk day. And it is an expectation that Department of Health puts out a checklist that we do meet, and we discuss our high risk areas. We do have, nursing homes and rehabilitation centres in high risk areas, and that it is an expectation that we consider evacuating that day before, and not leave it to the last minute. So, we have written plans around that, and we have actually activated the hospital management team in a heatwave situation where we've become so bed blocked that we couldn't discharge people back into caravans and hot homes that didn't have air conditioning. And, when we were sitting on overflowing emergency departments for the same reason. So, we had to bring a lot of our allied health and social departments in to sort of find, remedies around that situation so we could keep the flow going. And it's not an easy task.
Yeah, sure. Yeah. Okay, thank you. I think some questions are relating to already answered, but another question probably relating to the what is the extent, you have a training or drills at the hospital, all nurses, or what extent nurses are involved in such training or drills?
Yeah, so look, the drills, the mass casualty drills is multidisciplinary. So it's doctors and nurses of all various levels. And some, ward clerks and PSAs. We get radiologists involved and pathologists as well, looking at their surge demand. And then primarily, to be honest with you, we have online training. It's pretty broad, and it's just really acknowledging that there's, plans out there for natural disasters and heat waves and severe storms, etc., and bushfires. But medicine's very hard to tap into, to be honest, and because I'm very biased with nursing, I tend to, particularly I focus around the emergency departments and give them in services. And when thunderstorm asthma season comes around in October, I'll be doing a lot of in-services in face-to-face now. We're allowed to in September in readiness for that. So they're aware of the signs and symptoms coming through the door and to think about thunderstorm asthma. Yeah.
Okay. So you would expect, like you obviously you are in charge for the increase the preparedness of nurses at your hospital. So
yeah.
Does it like depending on I guess the size of a hospital with how many nurses there, is it more likely you have a in charge nurse who does those disaster risk management for the hospital? I'm talking about resources of nurses who are in charge for those
Just
roles.
spreading the word out. Yeah.
Yeah.
So our hospital meets every day at 9:45 at a huddle, which senior management go to. So our operational directors and general managers. And I would be putting my hand up saying that, the emergency management branch, the Department of Health has put an alert out for such and such and need to spread the word. I'd also put it on the intranet. But, a lot of our staff don't have time to look at the intranet, and particularly a lot of our environmental services staff and orderlies and PSAs, patient service assistants, they don't have access to computers during the day. So it's about printing it out, putting it on the board notices, and also the best method these days, we put a message out on our SMS teams and on text messaging in bulk into groups, and that's really helpful for our what we call standalone nurses out in the communities. It might be for allied health, for midwifery. We have a lot of services in the home environment now, and particularly our mental health. And so we're virtually saying to them, they've got their own specific strategies. Look at your rostering. Make sure that, the nurse on for the 4th day of a heat wave is not in the car, and that severe weathers and to have the emergency radio on in the car, and just be mindful, reschedule your meetings, your hospital and home visits to earlier part of the day and not to the later part of the day, and all those things. And to also be mindful for the general nurses in the hospitals of their discharge policies, and making sure that, they're not sending people home into a hothouse or a newborn baby into a caravan, in vulnerable situations. So it just makes them think a little bit more. But, as I said, with technology, it can be our friend and can be our foe, because a lot of nurses these days is ticking a box on a computer program. And if it's not on that box, they won't think about it. So we need to start implementing, environmental health aspects, and to get them thinking about that. And often I question, are we nursing a computer or are we nursing a human being? And so to make them think about that, we need to have it evident in our IT structures as well.
Yeah. Yeah, pretty. I think I agree with you. So you provide a lot of information from the hospital-based the between communities. So let's move on to the some questions asking about the nurses undergrad, so more education. So there's a question: do you think disaster training should include as a module in nursing training during student time? So
absolutely.
Obviously.
So I have a caveat here, is that I do lecture 2 units in the Masters of Advanced Nursing. So I really am looking at the critical care nurses. And I started off with 12 nurses back in about 6 years ago now. And it was during the pandemic. We did it all online. And most of them were international nurses, and nurses, who come from Nepal and India and Asia and China, and they'd had catastrophic events that they'd lived through. Since then, and very little Australians, unfortunately, but since then, and the pandemic has really brought out a lot of interest in this field now. So I'm up to marking this weekend 78 as my first assignments for this semester. So my numbers have absolutely expanded, and they are senior nurses roles that we're focusing on. But my issue is that very poor undergraduates. So we're getting our, graduate nurses coming out, not even thinking about this, not even thinking about environmental impacts on their patient presentations. And yes, they're so concentrated on the, anatomy and physiology and getting it right, and drugs and all the rest. But you know, you've got to come from another angle other than just that. And we are taught, you know, the social determinants of health in our first year of nursing. Well, I was back 33 years ago. But I think we probably found it a bit hard to apply that in the high demands and technical demands of nursing these days, or else it's getting lost, I would say, and not being applied that well. So if we can bring it back, and completely disaster nursing is just not even mentioned at all here in our undergraduates, unfortunately. So that's a big step we need to climb. I haven't done any research on this. This is just what I know in Australia. But yeah, I think that's a big area that's lacking.
I guess, sorry, you know, that the governance of curriculum is done by differently, and quite strictly you required, you know, that what's the competency. So maybe one thread about climate change disaster needs to be implemented, in my opinion.
Absolutely.
Okay, so,
And the pandemics, I just wanted to add that the pandemics really highlighted this. You know, we ran out of nurses. We used undergraduate nurses, we call them Rusons here in Australia, and, you know, to help us out. But they had no concept or understanding of the implications of why, you know, and that we'd exhausted all our avenues, particularly in the pandemic. And we've kept them on, which is really good to see. So hopefully we're improving in some aspects there.
Yeah, okay, thank you. And another question is, what about climate change? It's a broad topic. Should be emphasized for undergrad nursing students. I think partially you said, but if you can, yeah.
So I think there's an urgency for this now because, you know, as I said, the frequency and intensity of disasters from natural disasters is almost a daily basis now. And I don't think nurses in total, undergraduate, postgraduate, are really prepared for a massive onslaught of displaced persons and populations that are going to eventuate around the world. So, and with, you know, damaged infrastructure and people having to move. And you can probably reflect that also on, you know, war-torn countries that we're seeing at the moment as well, unfortunately, not dissimilar. But are we prepared for that and for the long-term consequences where people can't go back to their, you know, normal living conditions? You know, hospitals are going to, I think, experience the brunt of that.
Okay, yeah, thank you. So another question is, she said, excellent presentation. So how can we help increase the public awareness of environmental health implications? So that's the question.
Yeah, I think health promotion, to be honest, and I think that really needs to be built into nursing, particularly right from day one and undergraduates right through, and we don't do enough of it. And, you know, it's perfect timing in the middle of a heat wave when I'm stripping layers off the elderly, undressing them when they've fainted in their sheds in the backyard, you know, to tell them that, you know, you can't be wearing this layer of clothing, and what strategies are you implying for heat, and do turn your air conditioner on and go and have a cold shower and drink plenty of water, etc. So, and, you know, don't leave your babies out in the sun where they'll become blistered skin and things like that. So opportunistic health promotion really helps. And in thunderstorm asthma, you know, we put flyers out in waiting rooms and things like that. But I think what's the most meaningful is nurses in their assessments and their treatment promoting this as they go along. And I don't think patients will forget that. And so, you know, that it is ingrained in them other than just staring at a poster on the wall. Next time when they get into such a situation or experience, you know, conditions that are unfavorable and affecting their health, oh, this is what the nurse said. But also, you know, other strategies. We have nurse triage phone now, and we have nurse on call, and they should be also promoting strategies, which they do, in preventing people presenting to a hospital. But, you know, we know heat waves are the most silent disaster killer in the world. It has the highest fatalities globally, and we're breaking records every year due to the poor recognition of heat-related illness signs and symptoms from the community. And in the heat wave that I spoke about with the gentleman's wife who died overnight, we had 375 people in 4 days within the community die of heat-related illnesses, and our public morgue was absolutely overflowing. And then, of course, on day 5, we had the horrendous bushfires of 2009, where 135 people, or 173 people, sorry, died during the bushfires. Now, the public inquest was done on the bushfires. It wasn't done on the heat and the high fatalities in the heat wave. And that was a big lesson here in Victoria. So hence, we started to put out a lot of warnings, particularly through the media, and 24 hours beforehand of really hot days and what strategies to imply. But, you know, people become a bit immune to that as well. So you've really got to catch them at the time that they're affected. And I think nurses have a role to play with that within the healthcare system, whether you're a public nurse, a GP nurse, or a primary care nurse, or a nurse in a hospital.
Okay, thank you. Thank you for the, I think, excellent answer. I think because of, you know, when it happens, response it's too late, right? Like we have to proactively, you know, mitigate or prepare. So that's the, I think, a main theme for from your presentation as well. Okay, thank you. So we don't have any more questions, and I think it's quite well. I think everyone, you know, that happy. I hope, and then probably Andrew, we could towards the ending, and I would like to say that Nyree is you know, coming to the Wadum Tokyo, so myself too. So if you know, among the you joining today and coming to Wadum Tokyo, there is a session for the nursing SIG as well. So please join and they say hello each other, and then as a nurse, yes, of course we can meet each other as well. Okay, so I think I'd like to pass on to Andrew. Would you like to add something?
No, just I'd like to thank everyone in the remote audience for participating, and we had a really great turnout for the presentation today. Thank you, Mayumi, for moderating and taking care of the introductions. And Nyree, thank you for presenting and sharing your insights and your experiences with everyone in the remote audience. We really appreciate it. I always say this at the end, or almost always say this at the end. Everyone who does these webinars for Wadum, they're doing this as volunteers. They're donating their time and their expertise, and we really do appreciate that.
Thanks for coming and showing an interest, and I look forward to meeting people, you know, and sharing my ideas, and like-minded people as well. They're very few and far between.
Okay, so I think we can conclude the webinar. And then thank you so much, everyone. And then we will be hoping to see you in Tokyo next time.
Bye for now.
Okay,
Bye.
thank you. Bye.